Okay, welcome everybody. This is James White here at the Stevenson Center in Calgary. I'd like to welcome everybody to this session. It's one of the CanSCMR monthly sponsored sessions for advanced cardiac imaging, mostly in the field of cardiac MRI, but we have a wonderful guest speaker today, who's Dr. Jonathon Leipsic, who is Vice Chair of Radiology at UBC, but is becoming increasingly known as a truly outstanding clinician scientist with a Canada Research Chair in Advanced Cardiac Imaging, and is currently the president of Cardiovascular, the Society of Cardiovascular CT. He's really a world-renowned and leading scientist in advancing the field, not only in the area of cardiac CT, but really across the spectrum of advanced cardiac imaging, and is really an outstanding radiologist and clinician scientist. So it's a pleasure to have him speaking to us today, and he's going to be talking to us about cardiac CT for stable chest pain. And I think that you'll hear some words that really will make you ponder whether or not we're on the verge of a paradigm shift in non-invasive imaging for the assessment of patients with chest discomfort. And I think it'll provoke some really interesting discussion at the end. So, Jonathon, please take it away. It's a pleasure to have you here. You're a great colleague and friend, and we really appreciate you taking the time.
Thank you so much, James, for both the opportunity and such a kind introduction. I don't know if it's entirely deserved, but I certainly do appreciate it. And I hope over the next 35 minutes or so, 40 minutes, I can, through my slides, convince you at least that we need to be having a discussion about how we test, or for that matter, if we test low-risk patients. But if we do, what is the appropriate paradigm given the evolution of technology, particularly with tremendous advancements in cardiac MR, at places such as your site and Montreal and elsewhere in Toronto across the country, as well as the evolution of cardiac CT. So without further ado, you can see my slides unless I hear otherwise. I'll assume you can, so I'll get going. So I do have disclosures related to this talk. The only one that's really salient is that I have received unrestricted grant support and have historically provided consultative services to HeartFlow, the makers of an FFR CT technology. So, this is a clinical case that was lent to me that I've used before. After reuse clinical cases, because as a radiologist, I don't see many patients clinically. So this is a patient that was referred to my friend's cardiac CT lab, but a very similar cases are referred to our lab all the time, as I'm sure to yours. 64-year-old white male who had chest pain when he was arguing with his wife. It intermittently awakened him from sleep, and it may have occurred once while riding his bicycle uphill, but it dissipated with continuation of biking. So, at very best, atypical chest pain. That being said, he's Caucasian, he's 64, he's a male, he's hypertensive and dyslipidemic, he's on medical therapy for both. When my friend, the cardiologist, saw this patient, he was mildly hypertensive and mildly tachycardic and mildly obese. So a test was then ordered. And as has been taught to me by Jim Min and others, my cardiology colleagues through my training in advanced cardiac imaging and through my practice, traditionally these patients are worked up in a very stepwise fashion as guided by historical training and by traditional AHA/ACC practice guidelines, which involve three sequential steps that you all know very well, starting with a history and a physical. The history, of course, to try and determine, based on Diamond-Forrester criteria, the likelihood of obstructive coronary disease based on angina typicality, although we know that's limited in a modern population given the fact that Diamond-Forrester were validated in the late 70s. Nonetheless, those questions are asked, as well as others related to the nature of chest pain. The physical is taken, and it's a lot easier to bring levity and make light when you're in a room with people than over the phone. But as I always like to tease, that when it comes to chest pain, obviously you're trying to auscultate for an LAD stenosis, but that's only modestly accurate and has limited diagnostic certainty. Nonetheless, it's an important first step, and I certainly, a good clinical assessment. On the basis of that clinical assessment and the Diamond-Forrester calculator or various other elements, of course, then the patient is typically referred for traditional non-invasive ischemia testing. as you all know, with the exception of a couple of sites on the phone, that's largely limited in Canada to treadmill testing, ECG treadmill testing, and nuclear myocardial perfusion spec testing with, modest provision of stress CMR, not anywhere near as much as it should be, obviously, given the relative lack of accessibility of MRI. And then PET, which is, as I like to say, a rumor in Canada with the exception of Ottawa and some, modest provision elsewhere. So on the basis of these non-invasive tests, the post-test likelihood is determined based on the presence or absence of ischemia and the overall burden. And then the clinical cardiologist, as you well know, then determines whether he or she feels that they should just continue treating this patient, not really knowing their coronary anatomy, with an assumption that they are unlikely to have high-grade obstructive disease, but with an assumption that they're likely to have atherosclerosis, given the fact that he's 64 and a male with risk factors, or in the setting of a positive ischemia test, perhaps refer that patient on for an invasive evaluation for possible revascularization. So you see that my colleague sent this patient for a nuclear perfusion study, and they did a stress only given their concerns with regards to radiation, and the study was entirely negative. As a result, my friend reassured the patient that, you're likely to have some coronary disease. We're treating you medically, though. We'll treat you to targets. Chest pain's very atypical. It's unlikely we're going to improve your quality of life because your symptoms are so unusual. And prognostically, you should have a very good prognosis. The problem is, as I always like to say, why I didn't go into clinical medicine, is that patients are at times annoying and oftentimes right. The patient comes back to my friend and says about 7 weeks later, says, "Doc, I had this chest pain again, and maybe you weren't clear on what I was asking, but I wasn't asking did I have a normal MIBI. I wasn't asking what my coronary flow reserve was, obviously. I wasn't asking if that reduced myocardial blood flow, but rather I was asking, do I or do I not have coronary artery disease? What are you treating when you give me hydrochlorothiazide? What are you treating when you're giving me my statin therapy? And do I have prognostically significant CAD such that I may in fact derive benefit from revascularization?" And I show this next slide really because I think it highlights our clinical scenario, and that has been a historical disconnect between traditional non-invasive ischemia testing and epicardial coronary artery disease. And it's not that nuclear myocardial perfusion testing is invaluable, and it's not that exercise status is invaluable, but neither of which are meant to localize or pinpoint anatomical coronary disease, but rather are markers of either advanced disease or of abnormal coronary flow reserve, which is largely driven not by the epicardial coronary arteries, but by the microvasculature, given the fact that the epicardial coronary arteries are actually low resistance, high capacitance vessels. So in this exact same clinical scenario of atypical chest pain, 60-year-old male, with a normal perfusion study, we've seen a whole gamut of epicardial coronary findings, be severe anatomical stenosis, to no atherosclerosis, to very mild disease, to severe stenosis in the setting of very adverse plaque features. All of which are, would be treated very differently, I would argue. And so some people, when I would show this slide, would suggest, well, that's anecdotal, Jonathan. That's really not the real world, and you shouldn't make something of just your few clinical cases. Well, of course, then I'd like to show this data to refute that if we look at data coming from the preeminent nuclear sites, such as Cedars-Sinai, Dan Berman's data from Journal of Nuclear Cardiology, as well as other data, that we know that ischemia testing by nuclear stress testing typically fails to diagnose CAD in a large number of patients. In fact, a perfusion defect in the 47 study meta-analysis published in Heart by Mahajan and colleagues had a sensitivity of 65% with an odds ratio of 0.79. But I think even more sobering, if you say, look, I'm not even, and I'll come to that in a moment, I suppose, sorry, I'm out of order, and if we look at Manesh Patel's data then, published in 2010, in the New England Journal, coming from the NCDR database, and then further iterated in the American Heart Journal in 2014, 400,000 patients in the cath lab in the United States, the majority of the patients that go to the cath lab do not have obstructive disease at the time of their invasive evaluation. And importantly, about 40% of them have no disease at all by angiography measures. This is not inconsequential, of course, 62% of patients not having obstructive coronary disease. And many people look at Manesh's data and the NCDR registry and say, well, that's not our practice. They're not taking good histories. They're not doing appropriate testing. But I think it's time that we, as in the field of cardiovascular medicine, come off our high horse and leave our ivory towers and start realizing that someone is putting this data in there. And if you look at your own sites as well, the prevalence of non-obstructive disease is maybe not as bad as this, but it's nonetheless not 15, 20%. It's probably closer to 40%. How about so-called significant or prognostic coronary artery disease? I've had people after I showed that last data suggest to me, Jonathon, CT just drives unnecessary invasive evaluation. I'm really not looking for single vessel anatomical disease. I want to treat according to courage and treat patients medically, and I don't really need to see their coronary artery anatomy to do so. Well, I would argue that you probably do, because if you rely on a negative stress test or only a modestly positive stress test, you can see that the sensitivity for the detection of left main disease or triple vessel disease in 2,300 patients is only 75% and only 40% specific. And if we look at one of the bastions of nuclear cardiology, a good friend, and I say this because he would show the slide too, coming from Dan Berman, if you say you're really concerned about left main disease or triple vessel disease, half of stress tests are only mildly abnormal or normal in the setting of severe left main disease. With 100 left main lesions at Cedars-Sinai, 56% of them had a moderate to severe defect, but 13 were entirely normal, and the remainder were only mildly abnormal. These are patients, if they were similar in their presentation to the patient I presented, that would likely not undergo an invasive evaluation with a normal ischemia test or a mildly abnormal ischemia test, and yet would be harboring a severe anatomical left main lesion. And then if we close just on the last point, that we look at data that comes from my colleague here at UBC, John Mancini, who served as the core lab for the Courage trial as well as the O trial. You can see this very elegant analysis that was performed by him and then published in JACC Interventions from the Courage trial. He looked at which trumped which with regards to clinical outcomes. And you can see here again, this is not stress CMR or PET, obviously, but nonetheless ischemia testing. If you look at the ischemia burden, someone with more atherosclerosis but very modest ischemia burden had a much higher rate of events, be it death, MI, or a non-ST segment elevation acute coronary syndrome, than someone with severe ischemia and very modest atherosclerosis. Similarly, someone with severe atherosclerosis and a significantly positive ischemia test has the most adverse prognosis, really highlighting the importance, I think, of the fact that atherosclerosis is a very important driver of downstream clinical events. So why should we consider CT? Well, I think from 2002 to 2008, really a lot of effort was placed to look at the diagnostic performance of coronary CTA. It shouldn't surprise us that coronary CT, as a strictly anatomical test, it's not a perfect test, but as an anatomical test, if the first clinical question being asked by the patient or the referring cardiologist is not what is the myocardial blood flow or what is coronary flow reserve, but does this patient not have obstructive coronary disease, coronary CT performs very favorably compared to other tests. Here I highlight 4 multi-center trials which highlight both the strengths and the weaknesses of coronary CT. We can see that coronary CT has consistently a high negative predictive value and an overall very high negative predictive value and a high sensitivity, and more modest specificity and positive predictive value. Nonetheless, a very good rule-out test and a reasonable rule-in test with regards to severe anatomical stenosis by invasive coronary angiography. Now, people look at this as an Achilles heel of coronary CT. The fact that its specificity isn't as high as its sensitivity, and I think it is a limitation. But I think with the evolution of both CT perfusion and FFR CT, which we'll talk about, we can hopefully even further enrich the population that undergoes invasive assessment following CT by performing these other downstream analyses, which I'll get to. And when I show this, people then will put out before me historical SPECT data that shows that it in fact performs very well as compared to invasive coronary angiography. And I would argue that that is largely historical. This is data that was published by Armin Zadeh in Circ Imaging late last year. I believe it was November. And this is data from the Core 320 trial, which I'm sure you're all familiar with, which was published in the European Heart Journal in 2012. And I think there was a significant delay, and I know this is being taped, and I don't know it for sure, but there was a significant delay in publishing this data because I think it was fairly sobering. This was a CT perfusion trial in which patients underwent CTA and stress CT perfusion and underwent SPECT and invasive coronary angiography. And this sub-analysis looks at the diagnostic performance of CTA as compared to SPECT for the detection of and the exclusion from anatomical coronary disease by invasive coronary angiography. And you can see the AUC is not as high as in the accuracy trial for CT, which was 0.94 or 0.95, but nonetheless 0.91. And here you can see that the area under the curve for SPECT, which is a much more modest 0.69, with a sensitivity of 61%. So, does SPECT have a role? Perhaps, but I really can't see in the modern day how it has a primary role in the first question of the detection of coronary disease, the adjudication of the need for revascularization or prognostication in someone with known disease. You can argue, but not as a first-line test, I don't think, for the detection of coronary disease. And here we can see then without prior CAD, CTA 0.92, and without prior prior known CAD, SPECT 0.67. Now, I know it was discussed before, and I think one of the real strengths and why we do a lot of cardiac MR, nowhere to the level, both volume nor academically, as many of you on the phone. But nonetheless, we obviously, it's a tremendous tool for evaluation of a number of cardiac conditions and benefits from the fact that there's no ionizing radiation. That being said, as shown here, through the integration of a number of dose reduction strategies, be it limiting your Z-axis coverage, adjusting your tube potential and tube current, using prospective trigger or high-pitch helical acquisitions, using a minimum tube acquisition time, using iterative reconstruction. We've driven the doses down, maybe not routinely to 0.5, certainly that's not the case at our site, but our median effective dose is sub 2 millisieverts now at around 1.7, 1.8 millisieverts. Does that mean we should be serially CTing people without indication? Obviously not. But should this be a concern in a 64-year-old male with obesity, hypertension, and dyslipidemia, and atypical chest pain? I personally don't think so. So coronary CT is a validated, viable alternative to ischemia testing clinically. So people will say, that's all ivory tower stuff. Where's the real world data? And as you probably know, there were 2 large randomized trials that were published in the last year. In fact, 3, Vinci, Scott Hart, and Promise, that were published in very reputable journals that looked at the diagnostic performance of cardiac CT. So if we look at the Promise trial being the first one, a randomization of thousands of patients between 2 strategies, a traditional stress testing strategy, and then we see the Scott Hart trial, which was performed in Scotland, both looking at the utilization of CT as an alternative. And while some would say that, and we'll go through the data, CT itself did not save lives in the Promise trial, but you'll see that if you do a deeper dive, that there was a signal to a reduction in MI in both of these trials, and there was a greater efficiency in the diagnosis of CAD, higher CABG rates, a lower rate of non-obstructive disease at the time of cath. So we look at Promise to start with, published by Pam Douglas in the New England Journal. They randomized not 10 tests and 3 patients, randomized again to anatomical CT and physiological testing. The hypothesis was that the use of CT-based strategy would result in a reduction in the incidence of death, MI, and hospitalization. And for those of you who do non-invasive testing, you know full well that's a very tall order. To actually save lives and reduce events at 1 year or 2 years in a non-invasive low to intermediate risk population is a tall order. Nonetheless, those were the endpoints. If you look at the outcomes of Promise, and we stratify them here, whether they favor CT or favor stress testing, you can see that the outcome at 2 years there was equipoise, no question. It was not a positive study. CT did not reduce death and MI at 2 years. It did, however, favor CT at 1 year. It favored stress testing when you included treadmill testing, but it favored CT when you looked at SPECT alone. It favored CT with regards to cath normalcy. I think the triage to surgical revascularization, while not a hard endpoint, I would argue that if someone underwent CABG and you identified 2 times more people that needed CABG with CT, that was unlikely to be sham CABGs, that these patients likely had significant coronary disease. We saw significantly greater adherence to statins, which we hope would drive better clinical outcomes, although we lack any randomized data to support that statement, I totally admit. And then there was equipoise in quality of life and cost. When we look at Scott Hart, which I think got less play in the lay press because it was done in Scotland, first of all, and non-NIH funded, but a very important trial. They looked at both the hard outcomes, but also the diagnostic certainty, which I think, I don't see patients, but I always talk to my clinical cardiologists, and when they're making decisions around whether or not they should cath someone or treat someone medically or not treat someone, there's a lot of uncertainty with the normal myocardial perfusion study in light of Dan Berman's data. Do they have a severe left main lesion? Very unlikely on a population basis, but on an individual basis, distinctly possible. So diagnostic certainty, I don't think, can be entirely dismissed. But when we look at the hard endpoint, you can see that the hard endpoint of coronary heart disease-related death, non-fatal MI, and non-fatal stroke, if we look at standard of care versus CCTA, borderline p-values, not significant, but a reduction in the hazard for both of these endpoints in those who underwent CT. Again, negative, but certainly a trend. I think if you'll give me that liberty amongst friends. So the final question, of course, that's asked, and people will say, well, you're showing there's some clinical utility here, Jonathan, but in the real world, CT drives unnecessary angiography and potentially revascularization. And I think there's certainly good data to suggest that statement is true. I think that we hope that that's decreased over time as the interpreting physicians get more comfortable and certainly reduce overcalling of stenosis, as the image quality gets better, and as the people in receipt of the reports are less reflexive in their referral of a patient with a mid-LAD lesion to the cath lab. Nonetheless, we need to do better. And of course, this is a very important clinical question. Should this patient with a mid-LAD stenosis be revascularized? And I always show this slide, and you guys know this data as well or better than I do, but the totality of randomized data to date does not suggest that revascularization needs to be guided that there's a significant benefit from revascularization when guided by anatomy alone, at least as an upfront strategy. I mean, we all know there are limitations to courage and limitations to Berry 2D, but I think we would all agree that in the absence of severe osteal LAD disease, that there's relative equipoise between revascularization and optimal medical therapy as an upfront treatment strategy, allowing for crossovers, obviously, downstream. And we do know that up until now, the only tool that has been shown to improve clinical outcomes in guiding revascularization in a randomized fashion is fractional flow reserve, which you're all familiar with. We know that that's the case both through the FAME-1 data, which showed that there was a 30% reduction in events in those who were revascularized by a fractional flow reserve as determined by an FFR below 0.80, as compared to those who were revascularized by angiography alone. We know that was also done in a cost-effective fashion. The problem is, as an anatomical imager, whether we do invasive angiography or coronary CT angiography, or even MR angiography alone, that there's an unreliable relationship between lesion-specific ischemia and anatomical stenosis. This is from the famous trial in non-ST segment elevation MI, published from from a group out of Melbourne, a multi-center trial, and it really highlights a very depressing finding if you're an anatomical imager. And that is, there's a significant number of patients with high-grade anatomical stenosis that are FFR negative. Here we can see above the 0.8 threshold. Similarly, there's not an inconsequential number of patients with anatomical stenosis below 70, maybe women with atypical pain, that are getting sent home from cath labs all the time, being told that they have modest anatomical disease, but they may very well have positive FFRs. And this is not new data, of course. This is very similar data now shown for CTA by Bob Meijboom from the Thorax Center, published now in 2008, where an anatomical stenosis by CT is as likely to be FFR negative as it is to be FFR positive. So where can we go? I mean, there's a lot of options following the diagnosis anatomical disease. We can do things such as hybrid testing, as it's been pioneered by people, our colleagues in Ottawa, and Johanni Kanuti and others in Finland, looking at utilizing downstream PET testing. Certainly SCCT has been shown to be effective by a number of groups on this phone, and groups from Holland as downstream adjudication of that likelihood of FFR positivity. But another option now is deriving through the integration of computational fluid dynamics an FFR from a resting coronary CT angiogram without any additional downstream testing, without any change in radiation or change in protocols, and without the administration of adenosine. There are additional costs, at least with the offline testing, in that it does require computational post-processing, and that's associated, at least in those countries where it's available clinically, with increased costs, but no additional testing. So how can this be done? Well, this can be done by essentially integrating knowledge that has evolved really over the last 150 years, dating back to Newton's laws of mass conservation and momentum balance, and then evolving through fluid dynamics through two very bright people by the name of Navier and Stokes that were able to solve the equations for pressure and flow and velocity across for all non-compressible fluids, for all Newtonian so-called fluids. The problem is this could never be applied to the coronary arteries because we lacked an anatomical model and we lacked the computational processing capacity to actually solve these much more complex equations than, for example, the equations of wind speed and drag on an aircraft or on a race car. But now, of course, we do have patient-specific epicardial arterial geometry from a good quality coronary CT angiogram. We know that the heart-vessel interactions hold true, that the allometric scaling laws relate pressure to flow, that the microcirculatory resistance is inversely related to the coronary size, that patients with more myocardial mass, I know you guys have a lot of research in Calgary looking at those biathletes and high endurance training, patients with more myocardial mass, of course, have more myocardial flow at rest, and let's say have angina at rest. We know that blood is a Newtonian fluid, so you can adjust the patient-specific viscosity based on hematocrit. We can actually induce hyperemia, theoretically, assume that maximal hyperemia is achieved by essentially data based on data derived from Bob Wilson's lab back in 1998 from the University of Minnesota. And then the equations that govern all fluid, inclusive of blood, can be applied to solve for coronary pressure and velocity anywhere in the coronary tree. So again, we have the finite element modeling, integrating the epicardial mesh and the coronary boundary conditions of the aorta and the coronary arteries. We know that there's an allometric scaling law that governs the amount of fluid, so there's really an abundance of physiological information from anatomical data that's ignored by the human eye. And that, I think, we're all seeing through machine learning and all of these advanced algorithms that are now detecting many findings on imaging that we're grossly ignorant to over the years. But this one is an obvious one, right? That if you have a bigger coronary, you have more flow. If you have a bigger fistula, you have more flow. We also know that the coronary flow relates to coronary size, and that's why you cardiologists tell your patients to exercise, of course, because, as there's more flow, as you pump more and you have more flow through the coronary arteries, they adapt and they actually enlarge over time and will remodel to develop a homeostatic level of shear stress. And then we can even go beyond that and look at that form-function relationship between myocardial mass and epicardial coronary size as well. And finally, the boundary conditions are very important. The pulsatile flow can be then measured or calculated based on time-varying, intramyocardial pressures. And then finally, the induction of hyperemia, which assumes we know that hyperemia plateaus at 140 micrograms per kg per minute. That's why when you, of course, do your stress CMR, so that's the dose you use. And, many will say that assumes that the patient will achieve hyperemia at the time of the cath lab. And you're right. But that's why FFRCT is a conservative assumption, because if they don't achieve maximal hyperemia at the time of the cath, the measured FFR will actually be higher than the FFRCT, making sure that you don't deny someone with your non-invasive tests of potentially life improving, if not morbidity, if not mortality improving, FFR measurement and revascularization. So some examples, we see a true positive, FFRCT here on the top, atherosclerosis, moderate anatomical stenosis, How severe, I'm not sure. Does it really matter? I think what matters now is we know the patient has atherosclerosis. We know the patient likely will benefit from medical therapy, but should they go to the cath lab? If we look at the measured FFR, I would suggest that extensive atherosclerosis is associated with significant pressure drop, as noted by the FFR-CT as well. Interestingly, we see this lesion, very high-grade focal lesion, at least by CTA, and not maybe as high-grade by invasive angiography, but nonetheless fairly high-grade, and yet by measured FFR, fairly compellingly FFR negative. And here we can see the corresponding true negative FFR-CT of 0.87. If we look at the diagnostic performance of FFR-CT as compared to the invasive gold standard of lesion-specific ischemia of FFR, we can see the most contemporary data, which is the NXT data published by Bjarne Norgard and Jack in 2014. And when we compare again to measured FFR as the gold standard, you can see that FFR-CT in red far surpasses not only CT, but also invasive angiography with a drastic improvement in specificity and positive predictive value without a significant sacrifice in sensitivity or negative predictive value. I'm going to go see a respirologist after this. I apologize. And really, I think the strength of the FFR-CT, if there is one, is the ability, especially in sites where CT is driving unnecessary invasive assessment, is perhaps, and those aren't necessarily sites doing high volume with very expert readers, but perhaps sites that are doing less volume, where also the clinical cardiologists are less comfortable treating people medically and they're just referring patients with moderate anatomical disease right to the cath lab, there's greater comfort in actually deferring invasive assessment by integration of FFR-CT and reclassification of these 50 to 70% mid-LAD lesions as being so-called true negatives by FFR-CT and by then as adjudicated by measured FFR. We've also looked at the diagnostic performance of FFR-CT in the number of populations published recently in JCCT, that the area under the curve as compared to invasive FFR for the discrimination of lesion-specific ischemia is comparable in men and women. I think this is also another potential clinical utility, which is intermediate stenoses. You know, it's easy to say, if we send this patient, for example, with exuberant atherosclerosis and a moderate anatomical stenosis by CT, and we see all this plaque, and we send that patient to the cath lab. They go to the cath lab. She's a woman. English is her second language. She's kind of heavy set. She's not very active. She doesn't look like that picture from the Netter textbook, and she doesn't answer your questions like she has classic angina. And then you cath her, and you see that lesion. And I'm confident the overwhelming majority of such patients are just sent home from that cath lab, being told that they have microvascular disease or mild anatomical coronary disease. But you can see that we wouldn't necessarily have been wrong by CT, because that patient has probably very extensive plaque, and that may in fact be driving down that measured fractional flow reserve to a true positive 0.71. So look, and so the cath people are very quick to tell us, you know, you're sending us too many of these patients with a 50 to 70% stenosis. But they're also very quick to ignore their own data and realize that many of these patients, perhaps where we're overcalling anatomical stenosis CT because of exuberant plaque, maybe many of those patients are actually FFR positive. So can we use CT to help us with this difficult clinical question? Prox-LAD lesion, intermediate stenosis, low-density plaque, outward expansion, you know, not plaque we would want in our coronary arteries, but not a high-grade lesion. Should this patient be cath? You know, if you just send them to the cath lab, they're likely to yell at you saying you overcalled stenosis, Leipsic. So how about FFR-CT? Well, you can see that FFR-CT can be quite helpful. If you cath this guy, you may not be that convinced that this is a high-grade lesion, but perhaps if we send the patient to the cath lab with an intermediate stenosis and a strongly positive FFR-CT, that will behoove the invasive or the interventionist to actually measure the fractional flow reserve and determine whether or not that lesion is driving a pressure gradient across the stenosis. Here we can see data. This is, from the Discover Flow trial. This is now a few years old that Jim and myself published. And you can see that there was a 35% improvement in accuracy in these intermediate stenosis with a significant improvement in specificity as compared to CT alone. Finally, what's the reproducibility of FFRCT like? It's actually better than FFR. Granted, it's computationally modeled, but if you redo the model entirely and rerun the analysis, you'll actually have more reproducibility than the invasive gold standard. And to close, what are the other potential benefits of FFRCT? That would be in this setting of calcification. This is actually no longer in press, but it's actually in print in January in JACC Imaging by our colleague Bjarne Norgard, again from Aarhus, Denmark. And you can see that FFRCT is not immune to high calcium, but it's significantly better than CT alone. So here we can see low to mid Agatston score, high Agatston score, low to mid, and high Agatston score. Now for CTA in the dash line, and for FFRCT in the continuous line. And you can see that when you look at the continuous line for high Agatston score, the diagnostic performance, the area under the curve is 0.86, which is actually better than CT alone, even with a low Agatston score. And similarly, if you look at stratified now, this is in patients with even higher level and known disease, you get similar diagnostic performance. So how about some clinical cases? We have a patient with suspected disease. We have calcium. Can we use it? We have a calcium score of greater than 400, and you can see that the specificity starts going down for FFRCT, but nowhere near the way it does for CT alone. Here with FFRCT, the specificity of 69% with a calcium score of greater than 400, the accuracy reduced, but still a significant incremental bump over CT alone. So let's look at some clinical cases again. So here's a patient, 65-year-old with hypertension and dyslipidemia. You can see that the Diamond-Forrester classification, which needs, I think we would all agree, contemporary reappraisal, that would suggest that there's a 60% likelihood of obstructive coronary disease. A treadmill is done. The problem, of course, with the treadmill is that if you do a treadmill, you're left with even a negative study, a post-test likelihood that's probably too high to ignore. So they elected here, in this case in Monzino and Milan, to perform a coronary CT angiogram. The coronary CT angiogram was performed, and we can see here atherosclerosis in the proximal LAD with an intermediate stenosis. They deemed it to be 60%. They would put it, right in the 50 to 70% level. What should you do? Should you send this patient to the cath lab? I probably wouldn't. At our site, we would probably just treat this patient medically. But, can I be certain that this patient doesn't have lesion-specific ischemia? Can I be certain that this patient wouldn't at least derive a significant quality of life benefit from, or an angina relief benefit from an FFR-positive revascularization? They elected in Milan to send the patient for an FFRCT, and you can see the FFRCT is negative at 0.83. Patient was followed to a year, no clinical indication for ICA, no events at 1 year's time. How about in the setting of calcium? Here we see a calcified lesion again. Sorry, I'm running through this, but this is just clinical history. High pretest likelihood of obstructive coronary disease, an older male patient. A negative study, if a treadmill is still not going to reduce your post-test likelihood low enough to probably not undergo other evaluation. Here's the coronary CT angiogram. I think we would probably just dismiss this patient, but there's significant calcium, as we all know. That's an Achilles heel of cardiac CT. How severe is the stenosis? Probably modest, but in this case, greater confidence by a negative FFRCT of 0.88, thereby allowing them in Milan to safely defer this case. And again, no clinical event at 1 year's time. So are there issues with FFRCT? Obviously, it's not a dumping ground for poor quality CTs. You need to actually perform best practice CT. You need to rate control your patients. You need to administer nitroglycerin. If you don't give nitroglycerin, there's an assumption of vasodilation. If it's not given, that's a problem that results in unfortunately false positive FFRCTs. So it's not without limitations, without question, and we certainly have to do our part to make sure that the image data that's sent off for analysis is best as possible. So for the final 5 minutes, I thought I would close on the clinical utility of FFRCT. I'm sure some of you are aware of this trial. It was presented as a late-breaking clinical trial at ESC and published online in EHJ by Pam Douglas, Manesh Patel, and Gianluca Pantone, and others. And it was a pragmatic, non-randomized clinical trial. And this was for patients. There were really two arms. There's the non-invasive arm, which is cohort 1, These are patients that were referred for clinically indicated usual diagnostic care. So they were referred for non-invasive testing. Traditionally, non-invasive ischemia testing in Europe, echo or SPECT or PET or or stress CMR or treadmill testing. And then the second arm would be those that were traditionally referred for invasive testing. So they're already going to the cath lab. So there's two separate arms that are being evaluated. And in the roll-in phase, if you're in St. Paul's Hospital, you would just have whatever testing you wanted non-invasively. And if you were in the roll-in phase and you were in the arm B and you were referred to the cath lab, you would just have your cath. Then there was a hard stop, and then cohort 2 started, so it was non-overlapping cohorts. If you were in now 2A, where you were referred for traditional non-invasive testing, you would then undergo CTA first instead of your non-invasive testing. If you were referred for usual care invasive assessment, so you're already going to the cath lab, they would say, hey, hold a minute before you go to the cath lab at the CTA, and if there was no stenosis in a vessel greater than 2 millimeters by 30%, no FFRCT. If there was, you'd undergo FFRCT, and if you were in the non-invasive arm, you would just be followed. If you were in the invasive arm, you would only undergo invasive assessment if you had an FFR positive lesion by FFRCT, and you would just be followed otherwise if you did not. The primary endpoint was the rate of ICA without obstructive disease between 1B and 2B at 90 days, so in the dedicated invasive arm, and then the secondary endpoint were quality of life, MACE, and resource utilization. So if we look at the endpoint, the primary endpoint of the invasive arm, in the roll-in phase, usual care, the prevalence of the incidence of obstructive disease at the time of cath was 27% in this multi-center study. Following the integration of CT and FFRCT, there was an 83% reduction in non-obstructive disease at the time of the cath, from 73 to 12%. But I'll highlight the prevalence or the incidence of obstructive disease was very comparable between the CTA arm and the direct cath arm, suggesting, at least without certainty, we don't know definitely that there weren't patients missed, but that the rate of obstructive disease was comparable, suggesting that CT and then FFRCT were successful in weeding out those without obstructive disease without missing a significant number of patients with obstructive disease, because the incidence of obstructive disease was quite comparable. Importantly, there were no adverse events in patients in whom ICA was canceled out to 1 year. When we look at the cost effectiveness data, this was published by Mark Latke and presented as a late breaker at TCT. You can see that without Medicare reimbursement, assuming an FFRCT value of 0, there would be a significant reduction in cost. Assuming an FFRCT value of $2,100, which is obviously much greater than I think any of us could afford to ever pay, there would still be a potential cost savings in an American model, given all the limitations of that, but nonetheless a cost-effective analysis performed by Mark Latke at Stanford. So I think I'm now 44 minutes in. I should stop, but I came across like a zealot. I probably am one. I'm sorry. I don't think CT is a perfect test by any means, and I think there are other non-invasive tests that play a tremendous role for coronary artery disease evaluation. But I think that at this time in 2016, I think that all of us in Canada need to be probably pushing for greater accessibility to both CT and MR as tests for first the diagnosis of coronary disease and then the downstream utilization of either FFRCT or stress perfusion MRI for the adjudication of the hemodynamic significance of said stenoses prior to invasive evaluation. So thank you again for the opportunity, and I look forward to any questions.